Welcome to another episode of the MEGIN Spotlight series, which focus on the utilization of MEG. We are delighted to have Dr. Jeffrey Tenney, the Clinical Director of MEG at Cincinnati Children's Hospital Medical Center. Dr. Tenney is a neurologist with a focus on the care of children with epilepsy, specializing in epilepsy care and clinical neurophysiology. He's also the President of the American Clinical MEG Society, ACMEGs. Hi, Jeff. Lovely to have you as a guest on our Spotlight today.
Hi, Gabrielle. Nice to be here.
So let's start off with the first question, Jeff. How did you first hear and learn about MEG technology, and why do you utilize MEG in epilepsy patients' care plan?
Well, I came to MEG when I was getting my PhD. I worked in functional MRI, and I happened upon a project looking at animal models of epilepsy. And so my project was focused on trying to understand the seizure networks associated with generalized type of epilepsy. And one of the things that I realized while I was doing that project was that fMRI didn't really have the temporal resolution that I was looking for to try to be able to sort of track a seizure and where it starts and how it spreads. When I was interviewing for residency positions, I met Doug Rose here at Cincinnati Children's Hospital, they had just installed an MEG, and that was actually the first I had ever heard of MEG before, but I was very intrigued with it. And so when I started here as a resident, I actually spent several years working on a research project looking at seizure networks in children, and then as I progressed in my training, I changed and started to work on the clinical aspects of MEG, and worked very closely with Doug Rose, and then that continued as an epilepsy fellow and also as a junior faculty, and then eventually he retired, and I took over his spot here as the clinical director. So I kind of came to it from the research end first, and then into the more clinical aspect.
So, Jeff, you've been the president of ACMEGs since, I believe, a year or two now, which supports MEG centers in delivering quality comprehensive care to people with neurological disorders. ACMEGs is an expanding professional organization with the highest level of competence in practice of clinical MEG and clinical credibility with 21 member centers. You and some of your esteemed MEG colleagues who we've had on Spotlights before as well from ACMEGs developed the 10 common evidence-supported indications for MEG in epilepsy surgery. Why was this an important paper for you to collaborate on, and what initiated this work?
I think the inspiration came directly from Anto Bajic, who's one of the former presidents of ACMEGs, and it was something that he had talked about for many years, and he sort of pushed to put it into a more formal form in this journal article. And I think the nice thing about it is that it sort of lays out very clearly the indications for clinical MEG, and also provides like an illustrated compendium to go along with that. And so, there were multiple authors of this paper. Each author submitted one or two cases that highlighted that particular indication. And the other is that these are sort of evidence-based indications. And so all of them have multiple references as well. And so I think it's actually a really valuable tool. We've gotten to the point where I think whenever we present an MEG case, we sort of highlight which of the 10 indications that this case sort of falls under. And so I think it's been very helpful. I think it's also a very nice way for people who are new to MEG to think about which patients they should consider referring, because some of the indications are probably patients they would not have previously thought about referring for MEG.
We're looking forward, like a little teaser, I guess, is that we are looking forward to recording a masterclass with everyone on that topic. So that's going to be interesting and exciting for us.
Yes.
So knowing that from a clinical perspective, MEG is primarily used in Cincinnati Children's Epilepsy Program, could you elaborate on some detail of how MEG technology is incorporated in the institution's operational flow?
Yeah, so I would say that MEG is a critical component to almost all of the patients that are being evaluated for surgical epilepsy treatment. And one of the things that I've talked about with my colleagues on several occasions is, whether MEG should be a first tier test, done along with MRI with prolonged DEG for patients that have intractable epilepsy, or should it be done more as a second tier test after all these other tests are completed for patients where the information is still unclear? And the way that we use it here in Cincinnati is that it really is this first tier test. And so um, typically what happens here is that patients get admitted for a week-long stay in our epilepsy monitoring unit where they get EEG for the entire admission, but they also get the other testing, pre-surgical testing completed. So they get an MRI, they get a PET scan, they get a SPECT scan, and they also get an MEG as part of that as well. And I think, if you go back and look at those 10 indications that we talked about, I think if you look through those 10 indications, those are almost all of the patients who would be referred for epilepsy surgery evaluation. So what that means is that almost all patients should be getting MEG as part of their evaluation. And I think for us, like I said, it's a critical piece, and it's not unusual for us to, have patients where all of the other testing doesn't really point us in the right direction except for the MEG. And so we have a lot of respect for it here, and I think it's part of it is because we've been using it for a very long time.
Thank you. That's great to hear. So a little bit more information now around a specific sort of case potentially. So we've asked you if you could share a specific epilepsy case that will illustrate how MEG was vital in the diagnostic process and outcome, and whether the outcome has changed for the patient afterwards. We often hear about patients not being considered to be surgical candidates when later having an MEG has actually changed this. So we're very excited to hear about a case from you today.
Yeah, and I think that the case that I pulled out is really a patient where the MEG really helped to point us to the right spot for the intracranial monitoring, whereas a lot of the other testing was not really that contributory. And so the case that I had prepared is a 16-year-old girl. Out of all the 10 indications, this one falls under the indication, which is an ambiguous bilateral pattern on the EEG. And so this is a 16-year-old female. She's left-handed. She has epilepsy with focal impaired awareness seizures. The etiology is unknown. She started to have seizures at the age of 12 years. And her seizures she has a loss of awareness. Her arm will raise with her eyes and her head deviated to the side. It's unclear a little bit whether that's the left or the right side. And then these may secondarily generalize. The other interesting thing is that during the seizure, she often will do repetitive behaviors. And so, family provides examples where she may be painting her nails and then all of a sudden she sort of paints all over the table and all over her hands. And then she's also had seizures when she's been doing cross stitching, where she ends up with these very bizarre stitches that she then has to redo. And then I also have a picture, I think, in some of the figures that we're going to include with this talk, where she was drawing a picture, and you can see that she sort of kept tracing over the same figure over and over again. And these seizures typically last about 4 minutes, and she was having multiple of them per month. The rest of her medical history was not contributory. Her development had been normal. Her physical exam was normal. We had captured seizures with scalp EEG that showed sort of a diffuse burst of slowing at the very onset with some intermixed spikes, and then there was a slight left frontal temporal predominance. And clinically, the patient was typing on her computer at the beginning, and about 20 or 30 seconds later, stopped what she was doing. She had a versive head turn to the right side, and then some dystonic posturing of her right arm, and then a figure of 4 sign. She had some additional imaging tests. Her MRI was normal. Her PET scan, as well as her SPM PET analysis, showed no focal hypometabolism. And we were only able to get an interictal SPECT scan on her, which showed some possible hypoperfusion in the left inferior frontal lobe. So she had an MEG completed, and we captured right pride occipital discharges that were seen better on the MEG than on the EEG, which is something that we see fairly often. And so our analysis kind of showed that the sources localized to the right mesial and superior posterior parietal lobe. And the way that we do things here in Cincinnati is we use sort of a variety of source modeling algorithms. And so we use ECD, Music, S-Loretta, and then we also use SAM beamformer analysis. And so and the way that we use these MEG results is that, the sources really become our targets for our intracranial EEG monitoring. And so it's not uncommon for us to load this into our surgical planning software so that the surgeon can use the MEG sources as targets for where the intracranial electrodes will go. And so when she had intracranial EEG with stereo EEG, she had initially bilateral symmetric electrodes placed, and we saw that she had sort of near synchronous and asynchronous spikes in the left and right mesioparietal lobe, where there was kind of a variable lead-in and some rapid spread, and there are also some spikes in the right and left hippocampi. And so what ended up happening was that additional electrodes were placed in the parietal lobe, and some of the frontal electrodes were removed where we didn't see much activity. She went on to have sort of a second phase of intracranial monitoring. And during that phase, we were able to capture seizures that had an initial spike in the mesial parietal region on the right, in which then spread to the left and right mesial parietal lobes. And so at the end of all of this, our hypothesis was that she had a right precuneus or posterior cingulate onset for her seizures that was suggested by the stereo EEG, and also was quite concordant with what we had found on the MEG. And so she ended up having laser ablation of that region using the MEG source as the target for that. And she's been seizure free since she had her surgery, which was in 2021. So a great outcome, and a patient where if we had not had the MEG, I think we probably would have had more difficulty determining where that seizure onset area was. I think ultimately patient would not have had as good an outcome as she did.
We're always really excited and happy to hear that a patient is seizure-free, following the sort of treatment. So I think that's always a great success for us. And we've met many patients actually at some of these advocacy groups, and it's a humbling experience when we have success like this. So that's great. Mm-hmm. Thank you very much for sharing that. Sure. We have one last question actually that we'd like to ask too. In terms of MEG technology and assisting in any sort of planned research projects at Cincinnati Children's, are you able to disclose any, or are you involved in research at Cincinnati, and can you share any projects with us?
Yeah, so the MEG system here in Cincinnati is one of our shared facilities throughout the institution, which means that any of the researchers can propose a project. They can be from any department or any division, and they can also be from the University of Cincinnati. They don't have to be associated with the hospital, and so we have multiple research projects that have happened throughout the years. We've had studies looking at very high frequency oscillations in epilepsy, as well as MEG as a biomarker for migraines. We have a researcher within our neonatology department who is working on an NIH-funded study looking at language development in preterm infants, sort of as they develop. And then we have a couple of projects that are specifically associated with epilepsy. One is looking at patients that have had a first-time single seizure, and about 50% of those patients will go on to develop epilepsy. But at the time of their initial seizure, we're not sure which group they might fall into. And so we have a researcher here who is doing MEG on patients that have had just one single seizure, trying to determine whether there's a biomarker that might help to determine which patients will go on to develop additional seizures and epilepsy, and which will only have that one single seizure. And then I have a current NIH funded study where we're looking at the use of MEG and virtual sensor analysis, specifically in the hippocampi and also sort of temporal and extratemporal regions, trying to determine if there are better ways that we can distinguish between patients who might have a clear temporal lobe epilepsy and those that have a temporal epilepsy plus syndrome, which those patients don't have quite as good an outcome after surgery, probably because their intracranial monitoring is probably not as extensive as it needs to be. And so that's something that we're currently working on.
Sounds like your lab is a very busy facility, which is great to hear.
Yeah.
We've come to the end of our discussion today, so thank you very much for your time today. It's been extremely informative for our audience, and always an honor for us to be able to share insights from MEG utilization in a prestigious and advanced institutions such as Cincinnati Children's Hospital. So to communicate this with the wider MEG audience globally is exactly the aim of our spotlights. So thank you very much for your support with that and your time today.
Great. Happy to be here, and I'm glad to be able to work with you to promote MEG.
Thank you. Thank you very much.